Which of the following should not be included in the differential diagnosis for Soji's tiredness and weight gain? Depression, iron deficiency with or without anemia, migraine, hypothyroidism, sleep apnea, and none of the above. Well, actually, depression can cause these symptoms, iron deficiency, anemia. Migraine patients have tiredness throughout the day. There's an increased probability of them having sleep problems, causing them to be tired. Hypothyroid is obvious, and of course so is obstructive sleep apnea. So none of these should be excluded in the differential diagnosis. So what is best to do for Soji at this time? What would you do? Give her a sleep medicine to tackle her insomnia that she talked about? Would you give her a weight loss medication to sort of help her lose the weight that she's been bothered by? Order labs and ask her to keep a sleep diary, discuss sleep hygiene, and have her come back in a couple of weeks with her husband. Or give her an activating medication like bupropion and ask her to call your office in a few weeks to see if that helps with her sleepiness and depression. The best answer here is to order some lab tests, ask her to keep a sleep diary, discuss sleep hygiene, and to come back in a couple of weeks. To give her a sleep medication at this time alone would not be wise, nor would it be just to give her a weight loss medication. And finally, it would not also be a wise idea to give her just an activating depression medication without doing any of those items listed in choice number 3. So Soji listens to your advice, and she returns in a few weeks with her husband, who confirms loud snoring and gasping. And she says to you, yeah, sometimes I have to sleep in the other room because my wife snores so loudly. And her sleep diary indicates that she's getting about 5 to 6 hours of sleep total per night when you look at the amount of time that she struggles to fall asleep and her waking up in the middle of the night. Now, she doesn't take any naps because, again, she doesn't have much time for it, and her tiredness rating on the sleep diary indicates that she's tired throughout the day. She's had some lab tests done since the last time, and they're all normal. She also says to you that the psychiatrist has switched her from citalopram to bupropion, and she suggests that she still feels just the same, if not worse. So you refer to sleep testing because you think the probability of obstructive sleep apnea is quite high in this patient. Now, Soji comes back to you in 2 weeks, and her sleep study confirms that she has obstructive sleep apnea. And notice her AHI is 51, meaning that 51 times an hour on the average, she's either not breathing or her breathing is substantially reduced. Now, as we said earlier, what a sleep lab will usually do is they'll fit them with a CPAP mask. And in fact, they did this and titrated her so that at 7.5 centimeters of water, it eliminates her apneic episodes. Now, she says she hates it. She says it's constricting, it's confining. She feels claustrophobic, and she doesn't really think that it's too sexy. Now, her husband is sleeping next to her and is making sure that everything is going well, and he actually has to at times remind her to put it on in the middle of the night. She's not feeling any better, and she goes back to what she wanted when she came in the first place. She wants a diet pill. Which of the following options for this patient would not be a good idea at this time? Change the mask, encourage perseverance, oral appliance, ENT consultation for possible surgery, or weight loss pill. Changing the mask is certainly a good idea, or trying to find a mask that she likes. But it's very important to encourage patients that they should persevere with a mask that they do in fact adjust to because of the severity and problems associated with obstructive sleep apnea. Sometimes a patient will say, I really don't want that mask at all, and they can't in fact find one that they like. So they can be referred either to an oral surgeon or to an ear, nose, throat physician for fitting for an oral appliance. What these are designed to do is to push the tongue downwards and the jaw forwards so that there can be more room for air. Sometimes an ear, nose, throat physician who is specially trained in doing surgery for obstructive sleep apnea can be consulted because a patient may qualify for this, especially when they're having trouble and not adjusting to any CPAP mask. Weight loss pill is not a good idea at this time because the other options are better. What do we know about CPAP and what it can do for a patient? Well, we obviously know that it can eliminate the apneic episodes, normalize their pulse oximetry, but what we find already with studies is that quality of life can be improved, cardiovascular disease can be lessened, blood pressure can be reduced, cognitive function can definitely be improved, and finally, we have evidence that it can improve on mood and lessen depression in those who are depressed. But again, despite everything that we do, compliance with CPAP is variable, anywhere from 65% all the way up to 80%. So that means that anywhere from 20 to 35% of patients will just not acclimate to CPAP no matter what we do. Now, this noncompliance may be the biggest barrier to effective use. Some patients experiencing sneezing, nasal discharge, dryness, abrasions, claustrophobia, and all the things that we talked about that Soji was actually complaining of. A little bit more information on how to increase CPAP compliance. We talked about the different masks. Some pictures here are available. There's actually more than 30 some that are now available. The patient should also be allowed to articulate their discomfort. They should talk about what's wrong with what's going on with them, and sometimes reassuring them, but also asking them to stick with the program may be the right thing to do. Now, adjusting the CPAP pressures isn't something that most primary care doctors will do, but it's something that you should encourage patients to do by going back to the sleep laboratory. Sometimes they will add some heated humidification, and this can make it easier for their nasal passages. But as far as their nasal passages, please be on the lookout for the possibility of polyps or allergies or any kind of obstruction, and treating that may be important for our patients. Sometimes when patients watch a videotape on obstructive sleep apnea and they see how bad the problem is, and maybe even watching themselves on videotape when you were sleeping, can be very sobering for them and give them motivation to go through with the CPAP treatment. Finally, a very interesting statistic is that when patients are followed very carefully in the first several days after being prescribed CPAP, seem to do the best as far as compliance. That is, when the patients are called on every day in the first 3 days of usage of CPAP, they tend to persist and continue to use. Again, talking about alternative treatments for obstructive sleep apnea, there are dental or oral appliances, there's airway surgery, and these are being actually revised such that initially this used to only be a uvulo-palatopharyngoplasty. But now there's hyoid advancement, there's sometimes even plastic plates that are applied in the pharynx, all in the hopes of opening up the airway and keeping it open. There are ways of having patients maintain a particular position when they're sleeping, which can lessen their degree of obstructive sleep apnea. Many patients actually will come back to you with a sleep study that says that on their back they have terrible sleep apnea, but on their side it's substantially reduced, if not completely reduced. In these patients, there's ways of having them stay primarily on their side, like using wedges or even having a t-shirt with tennis balls sewn on the back, such that when they roll on their back, they, through the night, will actually roll back onto their side. So positioning can be helpful. All patients who have a weight problem, obese patients, should be advised to lose weight, as it may in fact improve obstructive sleep apnea. Results are varied with how much improvement they will get, some of them optimistic, others less optimistic. Nonetheless, patients should be given this option. In 1 month follow-up, Soji comes to you and she's fitted with a pillow mask. She feels much better, she's less drowsy, and you do an Epworth on her and it turns out to be 10. So you ask her to return every 3 months or so to ensure that she's compliant and she's having good response to the CPAP. She's advised to follow up with a sleep specialist also, as they normally like to see the patient every 6 months to a year. Third case presentation. This is Richard. He's a 39-year-old gentleman who comes into you for the first time for no complaints. He just wants to establish himself with you. His past history, you find he has obstructive sleep apnea diagnosed 2 years ago. He's a little bit overweight. He has borderline hypertension, and he says that his previous doctor was just watching it. He's currently on no medications. He has a few drinks during business trips and dinners. He quit smoking a few years ago, but recently he's been smoking again. He has a wife, 3 children. He's a full-time vice president of sales in a national chain. Family history is significant in that his father died in his 50s of a heart attack.